Now we're going to go work our way down a little bit further to the inflammatory disorders of the smaller airways. We start at the top, we're working our way down. And we're going to start with bronchitis. Usually bronchitis is a viral etiology. It can occur at any age, and like most viruses, be more suspicious in winter time. It usually starts as an upper respiratory infection, and then the patient will develop a dry, hacky type of cough, and then actually the cough can become somewhat purulent. Usually, just because it's purulent doesn't mean it's bacterial. Don't be fooled by that all the time. You may need to exclude a pneumonia. A chest x-ray will be most helpful there, because a bacterial pneumonia on chest x-ray will show a certain consolidation, an infiltrate in one particular area. And the treatment for bronchitis, since it's viral, is usually just supportive treatment. Bronchiolitis affects the smaller airways also. Bronchiolitis is most commonly caused by respiratory syncytial virus. It is also a wintertime disease. So we see it peak in this country is January and February. It can also be caused by parainfluenza virus and by the adenoviruses, mycoplasma, which is not a virus, and all these other viruses. But always think of RSV first when you're discussing bronchiolitis. It's under 2 years of age. Look at the age of the patient. Most children, most people, by the time they're 2 years of age, have had at least one episode of bronchiolitis. That's universal. But not everybody gets sick enough to be hospitalized. The smaller the child, the greater the risk for a more severe disease. And these are the patients that get sicker, the younger ones. Again, January, February, they will get inflammation of the smaller airways. They get coughing, a lot of mucus production. And since the younger ones can't bring up mucus as well as we can, that's how they can get into trouble. They will have some wheezing, which may not be asthma at that age, but if they have recurrent episodes of bronchiolitis, and as they get older and they have recurrent episodes of wheezing, then you do start thinking of asthma as your diagnosis. It usually starts out as a cold, and then they develop a little bit more congestion, then a rattling type cough, and then difficulty breathing, and then they can get pretty sick. The peak days are the 3rd, 4th, and 5th days. Usually by the day 7, they're starting to get better. However, a younger child can run into more trouble, and the disease can last a lot longer. On exam, you can look at evidence of respiratory distress. So you can see tachypnea, you can see nasal flaring, you can see intercostal retractions, you can see abdominal breathing, and you can certainly auscultate rales, and you can auscultate wheezing. Okay. Complications of bronchiolitis include a viral pneumonia. They can have a bacterial superinfection. They can sometimes aspirate, and then they have all the mouth germs to contend with. And they can actually have apnea because they get tired and they just give up and stop breathing. The test is usually as a clinical diagnosis. You don't necessarily have to know if it's RSV or parainfluenza or influenza or any other viruses. You pretty much make the diagnosis of bronchiolitis clinically. However, you can do nasopharyngeal swabs to let you know exactly which organism it is. There's really not a treatment for it. Chest x-ray is helpful because it'll show a diffuse pneumonitis. It can also show areas of atelectasis and hyperinflation. The treatment is typically supportive. Even though there's wheezing, most of these babies don't have a lot of bronchoconstriction, so it's recommended you can try a nebulized beta agonist, such as albuterol, and that might help. If it helps, it's okay to continue. If it doesn't help, you don't need to give any more beta agonists. You can try a racemic epinephrine aerosol. If it helps, that's fine. If it doesn't, don't give any more. Steroids certainly have been shown to not work in bronchiolitis. This is a child with bronchiolitis. Many times what you'll see is just some perihilar inflammation in this area. This area doesn't look too bad, but you can see a little bit of things going up this way on the left side. Ribavirin has been used, but it's controversial. I doubt that you'll get asked that on the exam. It's too much trouble to set up, and efficacy is doubtful, so you probably will not get that on the exam. We do know, however, that you can prevent or attenuate RSV bronchiolitis by giving immune globulin. And the best way to give it is the intramuscular form. There's IV and intramuscular form, and it's given on a monthly basis to certain children at risk. Babies that were born prematurely, have chronic lung disease, were on oxygen as preterm babies, those are babies that may be at risk for more severe RSV, and they would get monthly injections of the RSV immune globulin.